Hey gang, this is Arjun, back with some more of that glandular magic we call endocrinology. Today we're going to cover the dark side of the endocrine system, or when endocrine goes wrong. As with our other videos, we here at First State Express like to ask questions, and it's not because we like to hear ourselves talk. Even though you could wait the 1 or 2 seconds it takes to hear the answer from us, I strongly encourage you to try to come up with the answer on your own. It'll help keep you engaged and give you sort of an idea of how well you actually remember some of this stuff. With pathology, I'm actually going to go a little bit heavier on the questions because for the endocrine system, knowing the pathology is really contingent on your knowledge of the normal actions of these hormones. So without further ado, let's jump right in. Cushing's syndrome is the cluster of symptoms that arises when a person has way too much cortisol in his or her system. Now, many of you probably have a mental image of this, but what does a person with Cushing's syndrome look like? Don't worry about being mean, by the way, it's just me here, I won't judge. The most infamous manifestation of Cushing's syndrome is the Cushingoid habitus, meaning the moon facies, the buffalo hump, the truncal obesity, and the peripheral wasting. But what causes Cushingoid habitus? What's the physiology behind the sequelae of Cushing's syndrome? To answer that, let's take another look at our cortisol physiology mnemonic. Cortisol, the high-strung gunner. So, if you watch the physiology videos, pause this video and try to think through the physiologic effects that cortisol will have on the body. So to use our mnemonic, cortisol the high-strung gunner is known for his many emotional breakdowns, so it makes sense that he epitomizes catabolism, or macronutrient breakdown. The gluconeogenesis, proteolysis, and lipolysis all cause peripheral wasting, but the mobilized macronutrients gotta go somewhere, right? And actually, that's what ends up depositing as fat in weird places, leading to the classic Cushingoid habitus. And remember, as part of the catabolic profile, cortisol increases insulin resistance, which can lead to the development of type 2 diabetes. As per our mnemonic, the gunner's always running around with a sky-high blood pressure. He's emotionally fragile, which is mirrored by structural fragility in these patients. Bone growth and soft tissue repair are severely impaired, leading to osteoporosis, poor wound healing, and these big purple stretch marks called striae that come from gut expanding against fragile abdominal skin. The stress makes him sick, because cortisol causes immunosuppression. And finally, though nobody wants to mention it, our high-stress gunner is probably well on his way to some sort of legitimate mental disorder. One very common side effect, though not very commonly talked about side effect, is psychiatric changes, which can lead all the way from anxiety and depression to frank psychosis. Now these are all the effects of cortisol we talked about earlier, and they all become an important part of Cushing's syndrome, but the one important effect we didn't go over is menstrual irregularity that can potentially lead to full-blown amenorrhea. That's not entirely clear why cortisol disturbance leads to amenorrhea, but what you need to know is, it's one of a large collection of endocrine disorders that can lead to menstrual disturbance. We'll go over the rest in time. So, what causes the hypercortisolism that leads to Cushing's syndrome? As we briefly talked about in the physiology section, Cushing's syndrome is usually iatrogenic. That means that the Cushing's syndrome that we usually see is due to the effects of these wonderful multi-purpose prednisone pills that are prescribed for just about every autoimmune disorder ever. You should suspect iatrogenic Cushing's syndrome if the patient has a history of medication for autoimmune or inflammatory disorders, transplant, neoplasia, or severe asthma or allergies. With organic Cushing's syndrome, on the other hand, the most common reason is secondary hypercortisolism, caused by an ACTH-secreting pituitary adenoma. This is followed by primary hypercortisolism, which is caused by an adrenal tumor that directly secretes cortisol. Now, one important point, the former is also known as Cushing's disease, which is important to distinguish from Cushing's syndrome, which is the umbrella term. Can you remember what the final commonly tested cause of Cushing's syndrome is? Hint, it's not caused by a problem with either the hypothalamus, pituitary, or adrenal glands. The answer is paraneoplastic Cushing's syndrome, or Cushing's syndrome caused by an ACTH-secreting ectopic tumor. Now remind me, what's the most common kind of tumor that secretes ACTH? The answer is small cell lung carcinoma, or SCLC. Now, small cell carcinoma is also known for secreting ADH and being involved in Eaton-Lambert syndrome, which is kind of like myasthenia gravis. And I encourage you all to review the lung cancers in the respiratory section, which I recommend because there are definitely other paraneoplastic syndromes caused by lung cancer. So, obviously a diagnosis of lung cancer requires drastically different management than non-malignant pituitary adenomas. But how do you find out what's causing Cushing's without doing a full-body CT scan on every patient? Well, how about we start off by confirming that this is in fact Cushing's syndrome. Remember, not every obese person with stretch marks has hypercortisolism. So how can you confirm that the person's cortisol is running too high? Be careful. Cortisol varies by time of day, so you gotta be careful about your reference level. After all, a certain value might be high for midnight, but low for the morning. The most accurate and convenient test is a midnight salivary cortisol level, because this is when cortisol should normally dip down to its lowest level. See, not only do tumors cause elevated cortisol, they also don't really exhibit the normal variation that they should. So midnight's the time when, in theory, you're going to see the greatest variation between what you'd see in a normal patient and what you'd see in a patient with a tumor. Another way to tell is by measuring a 24-hour urinary cortisol. But that's less convenient and not even that accurate. Personally, I'd go with the option that doesn't involve me collecting a day's worth of stale pee. So that'll pick up most of the etiologies of Cushing's syndrome, all but which one? Actually, it's the most common cause, iatrogenic Cushing's. Remember, these patients don't get straight cortisol. They get synthetic glucocorticoids like prednisone or beclomethasone or what have you. And while those act like cortisol and feedback suppress the HPA axis like cortisol, they don't show up on tests as elevated cortisol. In fact, the body's endogenous cortisol will actually show up as decreased. Not to worry though, you can almost always tell from the question stem if the patient's taking oral glucocorticoids. For causes of organic Cushing's disease, however, we use something called the dexamethasone suppression test to distinguish between them. Dexamethasone is an exogenous glucocorticoid that works just like I was telling you. Except this time, we're measuring the ACTH levels instead of the cortisol levels. Now, what should ACTH levels normally do after a dose of the dex? So dexamethasone suppresses the entire HPA axis, decreasing CRH, cortisol, and yes, ACTH. This is what you should normally see, but this isn't what always happens in abnormal cases. And based on the response to the dex suppression test, you can tell for the most part who's responsible for the increased cortisol. A positive response to the dex suppression test basically implies that if you give someone dexamethasone, their ACTH drops like it's supposed to. Different types of cortisol increasing tumor are variably responsive to dexamethasone suppression. An adrenal tumor that's constantly secreting cortisol is probably the simplest scenario. What do you think ACTH is going to look like? Even if you have no dexamethasone, the increase in cortisol is going to suppress ACTH. Will ACTH be further suppressed if dexamethasone is added? That's the money question. And the answer is, not significantly. ACTH is pretty much already at rock bottom because of the heinous amounts of cortisol that these tumors secrete. How about the tumors that secrete ACTH, like the pituitary and the ectopic tumors? Now the ACTH will understandably be high, but will dexamethasone suppress the synthesis of ACTH? As it turns out, high doses of dex will suppress ACTH in a pituitary adenoma. I mean, sure, these cells are like cracked out versions of normal pituitary basophils, but at their core, they're still pituitary cells with normal feedback mechanisms. Ectopic corticotrophs, like small cell lung carcinoma, are not proper endocrine cells. These are neuroendocrine cells in the lungs that somehow mutated the ability to secrete ACTH during tumorigenesis, but not the feedback mechanisms to shut it off. Therefore, even high doses of dex are not going to shut down ACTH production. Now by that same logic, how should the pituitary adenomas and the ectopic corticotrophs respond to CRH stimulation? And this is kind of the same. Because pituitary cells have regulatory mechanisms built in to upregulate ACTH production, ACTH and cortisol will increase when CRH is administered. Now you will not see that in ectopic tumors. After you sort of narrow the diagnosis down based on all this testing, you usually use imaging, generally in the form of MRI, to confirm or classify the tumor, possibly prepare the patient for surgery. Alright, bet you've heard enough about Cushing's syndrome for one day. Let's wrap this up with a flash quiz. Here's a quick but a high yield point. A patient with a Cushingoid habitus states that he does not take any prednisone or other steroids. What's the most likely pathology leading to his condition? Pause the video if you need to think about it for a sec. And the answer is pituitary adenoma. This condition, also known as Cushing's disease, remember not syndrome, accounts for over 70% of organic Cushing's. Adrenal tumors account for just over 15%, and ectopic tumors account for just under 15%. other end of the spectrum is adrenal insufficiency, where, for some reason or another, there's simply not enough cortisol to go around. Now, I know I've been ragging on cortisol this entire time for being a huge downer, but the fact of the matter is it's an extremely vital hormone, otherwise we wouldn't have it around. The effects of cortisol aren't as obvious as you might think. It's not like it's exactly the opposite of Cushing's disease. A big part of the syndrome is that insufficient cortisol can cause some pretty crummy GI symptoms like nausea, vomiting, and cramping pain. This means that the patients don't eat as much as they should, and combined with the loss of catabolic activity from cortisol, they're pretty hurting for nutrients. Let's put it this way. It's like the patients are fasting because they're not eating enough, but their cells suck up nutrients like they're in the fed state. This leads to both weight loss and fatigue, and in severe cases, hypoglycemia. One of the other issues is hypotension, because remember, cortisol normally increases vascular tone. These are the consequences of decreased cortisol, and yes, there are some disease states that cause isolated drops in cortisol. The most likely one you'll need to know is, again, iatrogenic, and it's caused by abrupt withdrawal from a long course of exogenous glucocorticoids. When the body becomes accustomed to a certain level of exogenous steroids, it shuts down its own production, and until the body can pick back up, you get the symptoms listed below. That's why a taper is generally recommended if someone's been on steroids for a while. Now, this is a type of tertiary hypocortisolism, and what do I mean by that? It means that the deficiency is caused 2 levels up from the endocrine gland itself. Primary means the adrenal gland, secondary means the pituitary, and tertiary means the hypothalamus isn't secreting enough CRH. Now, this is an important set of terms you should know for the rest of endocrinology, so store that in the back of your head. But remember, the title of this section is adrenal insufficiency, not cortisol insufficiency. There's a couple of important diseases that wipe out the entire adrenal gland, and this really is bad news bears. Now, what other important hormone are you missing out on when your adrenal gland is destroyed? It's not the sex steroids. Your gonads are more than capable of producing that. The answer is aldosterone. And a combined aldosterone-cortisol deficiency, especially if it's acute, is way worse than a pure cortisol deficiency. Why? Well, ask yourself, what's aldosterone's main function? Sure, it increases sodium and water uptake and increases potassium excretion, but its overall main function is to increase blood pressure through fluid retention. So when you have decreased aldosterone, you have sodium and fluid loss, which also drops the blood pressure. Now, this really is the worst possible case of synergy, because you not only have the blood pressure drop from the water loss, but you also have the vasodilatory effect from decreased cortisol. To make matters worse, the sympathetic nervous system, which normally picks up the slack, ain't going to do jack in this case, because guess what norepinephrine needs to adequately constrict the blood vessels? You got it. Cortisol. It has a permissive effect on the sympathetic nervous system. So, what may have originally been a small potatoes case of orthostatic hypotension with an isolated cortisol deficiency may actually become lethal shock in cases of combined aldosterone-cortisol deficiency. In addition, you can get all the various cardiac and neurological consequences of hyperkalemia when you've got aldosterone deficiency, but you can check out the renal section for more details. When this hyperkalemic, hypotensive, hyponatremic, hypoglycemic mess happens acutely and severely, now that's a frequently lethal cocktail we like to call an adrenal crisis. These patients will come in crashing, seizing in shock, and or frankly psychotic because of all the metabolic and physiologic badness that's happening. And really, the best you can do for them at this point is supportive care. There are 2 causes of primary adrenal failure you need to be familiar with. The first is Waterhouse-Friderichsen syndrome, a disease that's caused by Neisseria meningitidis sepsis. And no, I don't know why it has a particular vendetta against the adrenal glands either, but it literally causes them to acutely hemorrhage. Now, this is the classic cause of acute adrenal insufficiency. And as a future emergency physician, I gotta make sure you all know this. What's the first warning sign for meningococcemia? It's all about the purple spots. And I'm not talking about that stupid morbilliform junk either. I'm talking about deep, purple, non-blanchable spots that go from 0 to humongous in a matter of minutes. You can read more about this in Micro, but just know that the typical population for this disease is healthy adolescents and young adults, classically college students and soldiers in boot camp, people who are in close proximity where they can transmit the disease easily. Addison's disease is the term for chronic adrenal insufficiency, which is usually caused by autoimmune destruction of the adrenal cortex. This usually presents more insidiously than Waterhouse-Friderichsen, but can present acutely in times of